do we need advancing mental health equalities? So that's the why. Then we'll move on to Jono McCutcheon from NHS England. Thanks for joining us, Jono. And he's going to talk about the NHS England Advancing Mental Health Equality Strategy. So that's what needs to be done. And finally, we've got Amar Shah on the AMHE Collaborative. So that's really how to do it. So building the evidence, getting a community of knowledge, learning from each other, and very importantly, expertise in quality improvement. Too often, the NHS finds out what the issue is, decides what needs to be done, and that's often absolutely right. And we throw it out there and we expect things to happen. And the AMHE Collaborative is making sure that we support people to ensure that something does happen and to ensure that they have the expertise to bring that about. So I'm going to introduce our first speaker. There will be a time for question and answers. We're a relatively small group, so we'll try to experiment with people actually putting their hand up, and we'll take your questions. But you could also put questions in the chat as well. If there are any unanswered questions, we'll try to get back to you within a reasonable period of time. So I hope that you'll find this interactive. So, and then Dominique, who has been managing this process for the Royal College, is going to talk about the next steps. So let's move to our first speaker, Lade Smith. Lade, thanks very much indeed for joining us and all the work you've done. You've done such a huge amount of work on this, and you're going to talk to us about why AMHE.
Okay, so thank you everyone for coming. I'm going to talk to you about the Advancing Mental Health Equalities work. I'm just going to give you an overview about advancing mental health equalities, and we call it AMHE. Can we go to the next slide, please? So, okay, so why AMHE? So this is really just to talk to you about the fact that essentially there's increasing evidence that if you have a protected characteristic, there's a higher risk that you'll have a mental health problem, and that your access, your experience, and your outcome in mental health services is actually worse than it is for someone who doesn't have a protected characteristic. So we know that people from ethnic minority backgrounds are much more likely to be detained under the Mental Health Act, and yet much less likely to receive psychological therapy for their problem. Next slide, please. We know that if you are from an LGBTQ background, then you're much more likely to have experienced depression and anxiety, and very importantly, suicidal behaviour when you were younger. And we know that nearly half of transgender people under the age of 26 have actually attempted suicide. If you are a young person, particularly if you are a looked after person, then you are almost one in two looked after young children are likely to meet the criteria for mental disorder. And weirdly, even though we know that if you can treat someone when they're a youngster, they're not likely to have a disorder as an adult, trying to actually accessing mental health support as a young person is really difficult. And you can see from the bottom of that slide that up to 3/4 of mental health problems emerge before the age of 25, yet many young people struggle to access mental health care. Next slide, please. And even if you're an older adult, unfortunately, it's very difficult to access older adult psychiatry. And if you've got learning disability, you'll know that you have a higher risk of mental disorder, but also you have a much higher risk of physical disorder as well. And again, we seem to be failing people. And very importantly, if you look at the bottom of this slide, you will see that if you are from a lower income household, then you are much more likely to have a mental disorder than if you are in a higher income household. And very importantly, we know that if you are from a deprived area, then you are likely to spend about a third of your life in poor health, compared with someone who's from a more affluent background, who's only going to spend about a sixth of their life in poor health. The reason this is important is obviously when you hear those kind of figures that there are these massive disparities, then next slide if we can have it, But there's these massive disparities, and what those massive disparities tell us is that we need to do something. There's a moral case, there's an ethical case. In fact, there's a legal case that as an NHS commissioner, you will be bound by the Health and Social Care Act to reduce health inequalities. There's a public sector duty on public sector bodies under the Equality Act to iron out any kind of disparities that we see. But yet again, we again and again, we fail to address this ongoing problem. The moral case, the ethical case, the legal case doesn't seem to have been enough to make a difference. The economic case is really compelling, however. We know that the cost of mental health problems is in the region of about 5.5 billion. The loss of productivity and the cost to the economy of that loss of productivity is in the order of about 30 billion pounds. So this is something that is an imperative to address for all the reasons that I've mentioned. And so next slide, please. What we have done is develop the AMHE resource, and the AMHE resource allows you to think about your population, and it helps you to think, okay, how do we identify the mental health inequalities and how do we address them? And it's a step-by-step program. Helps you to design services and initiatives in collaboration with your local communities to address the inequalities that you find when you work out who's in your local community. It helps you to develop and deliver a measurable strategy, and measurable is the important thing because you want to be able to make the change and see that change. And it helps you to learn how to evaluate the impact of the service or the initiative that you developed and how that's helped to reduce the local disparities and local inequalities. And in fact, NHS England have published this, the resource is published, and NHS England have now have published their Advancing Mental Health Equality Strategy, and Jono McCutcheon is going to talk about that shortly. Next slide, please. I think this next slide just shows you the steps, actually. You identify who your population is and what their needs are. You co-design and co-produce services with that local community. You deliver a service, which is, you create your strategy and deliver the service or the initiative, which needs to be measurable, and you evaluate it, and then you improve it as you go along. Okay. So they're the 4 steps of AMHE. I'm going to hand over now to Jono, who's going to tell you a little bit about the NHS England and NHSI Advancing Mental Health Equality Strategy. Thank you.
Thanks so much, Lade. Hi, I'm Jono McCutcheon. I work for NHS England and Improvement in the National Mental Health Team, and I'm part of a small unit that's looking specifically at inequalities in mental health. And I've been in the role for about 3 years now, so I was one of the lucky few to be first involved in the AMHE resource when it was being developed. But I'm here today to quickly run through the Advancing Mental Health Equality Strategy from NHS E&I, just to paint a bit of context about how the AMHE fits in within this broader sort of juggernaut when it comes to shifting the dial on health inequalities. So if we can skip to the next slide, that'll be fantastic. Thank you. Great. So the strategy was published in October 2020, which was timely. And we made the decision to push this through in the middle of the pandemic because we know that all sorts of inequalities were becoming really, really sharp and more apparent and part of the national conversation. So we wanted to really jump on that opportunity and make it clear what we think the priorities are from the NHS side to really make a change for the positive. And the strategy itself builds on the urgent actions that the NHS asked all health systems to take to advance equalities in the round in responding to COVID. Delivery of this strategy is overseen by a task force, which is an alliance of leaders and experts by experience from the mental health sector, which was formed early last year. And in summary, it focuses on 3 major work streams. So the first one is on supporting local systems, and in practice that means supporting the development of helping tools like the AMHE resource, but also some other more specific pieces of work, such as the Patient and Carers Race Equality Framework, which many on the line will recognise from the Mental Health Act review, and looks at sort of racialized experiences within mental health services for ethnic minority communities. We have also increased our commitment to invest in advancing mental health equalities via transformation and pilot programs. So if you're familiar with the long-term plan for England, there's an enormous amount of money going into community mental health services to sort of wrap around primary care networks and improve models of care. So as an example, it's a specific requirement that any site in receipt of that funding comes up with a tangible and deliverable plan to address inequalities within their local patch, sharing evidence where it emerges, and also looking at the levering and contracting arrangements underpinning provider collaboratives, which will be taking on the role of commissioning more specialised services, which is where inequalities tend to be the pointiest, and making sure that inequalities is really in the heart of that. Another important work stream that I think is definitely like a personal challenge is improving the quality and flow of data to national NHS data sets. We know that it's improved over the past couple of years, but we do know that there is definitely a culture shift required to make sure that that information is captured, that people are confident asking questions about protected characteristics, and that that information is flowed to national data sets so that we can do things like tie financial levers and incentives to positive change. Another thing that we are looking at right now is headline measures of health inequality, so that we can more accurately and on a more regular basis review how we're tracking in reducing disparities. The final work stream is focused on workforce, and most of this work is done in partnership with Health Education England, and there's a big part of it is looking at sort of like the res and how we can make sure that the workforce is diverse, is representative, and that training pipeline is representative, but also making sure that staff existing and in the pipeline are equipped and confident in calling health inequalities where they exist, understanding what we can do within the NHS to shift that dial, and supporting them with the skills and knowledge to make a difference in their roles. And we might move on to the next slide, please, Dominique. Thank you. So when it comes to Mental Health Trust's role, so many of you will remember that big moment, particularly in England, where we secured additional investment in addition of 2.3 billion by 23-24 to deliver the long-term plan. The prescriptive asks on services are documented in the Mental Health Implementation Plan, which I'm sure many are familiar with. And I guess we recognise that when it comes to health inequalities, local systems play a really crucial role in addressing them for two reasons. The first is because they are so varied across England, and you need communities to help unpick what the solutions are, but also because a majority of mental health services, especially those that are the first point of contact for people, are commissioned locally. So in delivering the implementation plan and the strategy, trusts are expected to pay particular attention to inequalities in access, experience and outcomes for groups with protected characteristics and other health inclusion groups. And we fully recognise and hear that lots of these inequalities come from sort of structural bias, they come from social determinants of health, but we are adamant and very much focused on what we can do within any NHS service to improve access for groups that we know don't access services as frequently as others, improve the experience for groups who might be racialised or have a poor experience of care because of a protected characteristic, and improve outcomes for groups that we know certain therapy offers don't result in positive change as frequently for. So when it comes to opportunities to advance health equalities in mental health trusts, what we often ask is for services to look at existing tools that exist, such as the AMHE resource that we're talking about, but also things like the IAPT's Black, Asian and Minority Ethnic Positive Practice Guide, which was co-produced with experts by experience and includes a really powerful audit tool that any trust can pick up, regardless of whether they're an IAP service or not, to assess sort of like the level of cultural competence of that organisation. Also, something that's quite critical is engaging with third sector and other community assets to co-produce local solutions. And again, appreciate that you can't co-produce your way out of structural racism, as our equalities advisor, Jackie Dyer, frequently reminds us. but there is definitely a really important role that communities and third sector organisations can play in this space, and a lot of learning that I think can be shared across the NHS generally. When it comes to improving data, I've mentioned already that capturing and flowing data is a very important thing, not just so that we can assess how we're faring, but also so we can tie financial levers and incentives to change to them. And when it comes to once we do have that sort of rich and robust data, then it's easy to pick up things like the AMHE methodology, where you can sort of plan and co-design solutions where there are issues. In terms of workforce, there's a clear expectation on trusts, as we know, to deliver against the Workforce Race Equality Standard, the RES, and the Workforce Disability Employment Standard. Something that is also a priority for us is exploring opportunities for community participation in care, such as peer support roles, and formalising that with our partners at HME. And another ask on any trust whenever we're on the phone with them is to sort of really invest in that training or enabling community outreach, fully appreciating that capacity is often limited in mental health trusts, but hoping that we can build and support that evidence base for co-production and how that can actually prove that there are like all sorts of efficiencies on a personal and economic level when you do involve communities in designing care pathways and evaluating services. And I think that's my 9-minute spiel, so I'll leave it there. And I do know that there'll be time for questions later, but if you've got any immediate ones, please do post them in the chat. Thank you.
Well, thanks very much, Lade and Jono. So that's the why and the what. So I'm now going to pass on to Amar Shah, who's going to tell you about the AMHE Collaborative. So Amar, over to you. And just a reminder, we are recording this session, and that's so that anybody who hasn't been able to access it live, that you can see it at your leisure, or any of you, if you wanted to watch it again or show it to others, you'd be very welcome. So Amar, over to you.
Thanks, Adrian, and thanks, Jono and Lade, for setting out the case for change and the sort of policy framework. The opportunity really that we're offering is to be part of an improvement community and to have help and support with applying quality improvement to tackle the gaps that exist and the inequalities that we are aware of. Just looking through who's on the call, I know that you've all got experience with leading quality improvement and seeing the effect that it can have within your services at achieving transformational change. Many of you have participated in some of the national improvement collaboratives we've already been running through the college on big complex topics in mental health, such as restrictive practice or sexual safety or suicide prevention. So this is our next offer really, which is focused on this important topic of advancing mental health equality and applying a quality improvement approach to it. Next slide, Dominique. So the aim that we're going to be working towards for whoever wants to join this community over the next 3 years will be to improve mental health services for people who face systemic inequalities. And we're going to be working in 4 different areas around experience, outcomes and access, co-producing as all of that work together with those who receive our services on receipt of our services. And we're going to support every provider to really continuously understand better their population using data and information to help understand the needs and assets in their communities. So we're going to be working with you all towards this goal over a 3-year program. And here's some of the support that we're going to be providing if you choose to take part in this program. It really builds on some of the learning over the last 3 years of running big national programs like this using quality improvement. If you can keep going, Dominique. And just keep flicking through the next slide. You'll have access to resources, both content resources around the AMHE toolkit and other relevant sources of knowledge. You'll also have access to people who are experts in this field who can guide you and support you with ideas you want to test out in your organisation and your system. Keep flicking through, Dominique, please. You'll be able to have some help to really understand which should be your priority populations, knowing that we have multiple populations that we serve in any organisation. So prioritizing which to start with, really understanding from your data the disparities and how you might measure improvement. We're going to provide you with some support around co-production. So really thinking from the outset about how we can involve the people within these communities to help us learn how to improve their outcomes, experience and access all the way through this 3-year program. Keep going, Dominique. We're going to, as we've done for all of our improvement collaboratives so far, provide quality improvement support to your organisation from our team of improvement coaches. As I've mentioned, access to experts, which will not just include clinicians, but academics and service users as well, and support to collect data. Data in this field is often not as easily accessible as we might want it to be. The data that we all look at and produce and provide within healthcare often doesn't capture the things that we're really interested in this topic. So we're going to work together to think, what data would we really need to know to understand whether we're making a difference or not, and also some support around evaluation and then communicating and telling the stories of the work. Ultimately, it's about being part of a learning community, and that's been the real power of working on these big topics across the country, has been bringing teams together to learn what's working, what's not working so well, sharing ideas, taking those away and adapting them to our own local context, and just being part of a community that really applies improvement, having designed ways to come together and learn from each other in really effective short spaces of time. Keep going, Dominique. So what it means for your organisation is we know that there are lots of organisations already well on this journey, and there are others who are sort of at the starting point, and we will work with you wherever you are on that spectrum. In the spirit of continuous improvement, there's lots to learn from wherever you might be, whether you're right at the beginning or part way down this work. I think there's opportunities for all of us, and we're going to apply the systematic approach that quality improvement offers to really tackle this in a way that helps us to learn from each other. Keep going, Dominique. So there are requirements from you, as there would be for any quality improvement work. Capacity is the main one, so identifying a team, someone senior who can sponsor the work, finding time to do this work over the next 3 years, and some resource for this particular program over the next 3 years. So let me hand back to you at this point, Adrian.
Well, thanks so much, Amar, and really it's over to all of you for any questions or queries that you have. I think one of the things I would like to stress is the quality improvement networks that are running currently. The facts really speak for themselves in terms of the improvements. If you look at the reduction restrictive practices in organisations that have been part of that collaborative, so this is a proven methodology, and I've actually been involved in some of the projects myself, so I know that it works. So over to you. I'm looking at participants. I can't see any hands raised currently. Anybody got any questions that you'd like to ask? I will have a look in the chat as well. That was a whistle stop. Thanks very much. Oh, Amar, could you expand on organisational requirements?
Yeah, hi Barney. So I mean, the design of this work is going to propose that organisations participate rather than teams. So for some of our work on restrictive practice, for example, we've asked wards to come forward, but actually this is one that an organisation needs to come forward and participate in. What it will involve is some support that will come out to you, so supporting you to create a team, create your theory of change, understand your populations, figure out how you're going to measure, what tests of change you're going to run. And then there'll be opportunities to come together across the network. So that will hopefully be in person as soon as we're able, but in the meantime, it will be virtual. And spaces, we currently run, for example, a learning session every 2 months, where all the teams come together. We bring in content expertise, but also give teams a chance to hear what's going on across the community. So it's support for you in your organisation to do this work. But you'll need to find the capacity and resource to actually do the work. We can't do the work for you. So you'll obviously be in the best place to do the work with your service users and local communities, but we will be able to guide and support you with it. And then opportunities to learn together with all the other providers that are taking part.
Okay, thanks, Amar. I'm going to go to the hands now, and the first was Laura Hobbs from my very own organisation, Devon Partnership Trust. Welcome, Laura.
Yes, thank you very much, Adrian, and thank you to all the speakers. Amar, most recently, and my question is for you. So we in Devon are very lucky to be part of a health inequality steering group that's been set up for the system, which is really helpful in one respect, because we are doing this as a coordinated effort. But my question is, obviously, our focus and our priority as an organisation is advancing mental health equality. Do you have, and I mean, it's a big question, I suppose, but I'm trying to make sense of how we would approach the implementation, going at it as an organisation and into the system, and how we might work on the quality improvement implementation in a sensible way without spreading ourselves too thin across those two areas. I don't know if you've got any thoughts on that, or if that's just going to pan out as part of the kind of network discussion.
Yeah, it's a great question, Laura. I think you know, we would certainly welcome providers and commissioners coming to this jointly in partnership. Because a lot of the factors related to the inequalities are systemic factors that are often outside of the walls of healthcare delivery. So I think there's an opportunity here to bring your partners in with you into the work.
Thank you, a very welcome answer. And I think in relation to this, at the heart of every piece of work we start in, whatever format it is, data about our population is the first thing that everybody is trying to solve and has been for years. So I think that we will. I've seen LiveWell colleagues on as well with hand up, and so we're very likely to all be trying to achieve the same thing. And that if we are able to do this, bringing partners in, that would be great. Thank you.
Okay, that's great. So Lynn, I think you were next. You're on mute. I think.
On mute. Do you know what? That is actually the comment of the century, isn't it? At the moment, you're on mute. Sorry about that. Thank you. Hi, Amar. Good to see you, and thank you, everybody. That was a really interesting presentation, and I'm already kind of in the planning stage of thinking things through. So I think I can see what a team would look like in terms of the kind of the people that would need to be represented. I think you're saying commissioners. Obviously, we've got in our organisation, we've got work underway around RES, so in the equalities lead, patient care involvement. Those are the kind of people that we would be thinking would make up that team. Service users, experts by experience. So it's that kind of team format, isn't it? I'm hearing.
Yeah, absolutely, Lynn. Good to see you. I think lots of places will already have groups of people to do this work. What I see much less of is a systematic approach to really understanding the population, measuring and testing changes, which is what I think this offers.
I completely agree, and I think that leads to my second question, which is what is the opportunity of using, sorry, my other phone's going on, what is the opportunity of using systems like LifeQI to actually develop this sort of collaborative approach? Because we've already had a few conversations locally about some of our colleagues in other providers that have actually got that set up. I'm just wondering what the opportunity is to kind of use that, because you're smiling, I know, but it just means that we're able to sort of gather the data in one place, have that shared set of aims and drivers and that systematic approach in terms of how we do it. So you know, often it can get lost on paper, can't it? And we've got LifeQI within the organisation. I think it's an opportunity to potentially exploit that better as well.
So the quick answer to that is yes, Lynn. All of our improvement collaboratives use that digital platform, and we would use it for this too.
Thank you. Great, thank you.
Thanks. Just want to ask whether Lade or Jono want to come in on the questions that have been raised so far, and then we'll go to the next ones.
No, it's just that I think that's already been said. This is something that you know, should be held at an organisational level, and so therefore I think there's something in the chat about whether you could do this at an STP level, and that would be fantastic, actually. Yes.
Okay, great. That's great. Jono, anything you wanted to come in on?
I was just going to say, yeah, I agree. I think taking that sort of wider system approach is really valuable and important.
Great. Okay, let's go to Arasu, also from the Southwest, from LiveWell Southwest. Great to have so many people in the Southwest on the call. So Arasu, over to you.
Thank you. Thanks for the presentation. I'm just picking on from Laura's conversation. I'm just wondering if it is worth influencing this through ICS down its next as well, or yeah. So from having the whole population view, and whether we drive this through provider collaboratives or ICS.
Yeah. So I might just say something about that. So I work at South London and Maudsley, and we're part of one of the first wave of provider collaboratives, the South London Partnership. And this approach, if you're about to start a provider collaborative, using this approach would be absolutely perfect. And we're actually starting to bring in some new services, and we're actually using the kind of AMHE approach in trying to design those new services. It works very well, actually. And if you were to start your provider collaborative using the AMHE approach, at the end you'd have a much better service and probably a lot leaner and more efficient, actually, I think.
And surely one of the things we need to lobby for is that this should be one of the leading strategic objectives for each and every ICS. If this is something that ICSs can't address, then you have to wonder, you know, what they are addressing. It seems so important. So I think it's a real opportunity with the ICSs to get this right up the agenda, and also we've got a very clear plan and a methodology. So Daniel Merron, over to you, Daniel.
Thank you, Adrian. Hey, Amar, I think this is excellent. It's exactly what we want to do, and we want to do it together. Can I ask, I asked in the chat, so we have a really strong culture of QI in the trust. We've been investing in that for years, and we would really like to do something that builds on our culture rather than introducing something different. Is there some flexibility around this for us to do this?
Yeah, absolutely. We would want to build on what you've got, Daniel, and you will lead the work. We won't be leading it. In the last 3 years, we've been working with every provider of mental health in the country, some of whom use different methods, for example, and it hasn't proven to be a problem so far, Daniel. So I don't anticipate it to be.
Thank you.
Okay, I'm going to go to the chat now. A question about do we have a proposal for the governance and infrastructure for providers? Who wants to have a go at this? Governance?
I'm looking at Amar, but I wonder if Tom's on, actually.
Well, if you're thinking about what a provider needs to put in place around assuring itself about outcomes and equity, then that may well become a focus for the work you do, and a place where you want to test some changes, and that will be an interesting place for us to compare and contrast and learn from what's in place already around the country.
Mehdi, you asked the question in the chat, and you've got your hand up now. Do you want to come in there?
Thanks, Adrian. Hi, Amar and all. I'm Mehdi Vaisi from Barnet, Enfield and Haringey Mental Health Trust. I suppose the question comes from the background of having some organizations having well-established population health methodology to some organizations that have none, and working along that side. And this is a discussion that I've had with my board quite often about how do we bring the inequalities into the agenda. Where do we sit it? Does it need a subcommittee of the board, for example, or does it need something looser defined within the governance of the organization? It's less about how many staff of a band 8A or 8, etc. we want. It's just where do you bring that meaty subject, ensuring that all of the transformation plans of the organizations are being ratified through this, because we are all rapidly changing the interface of community services within the next 3 years. And my concern over here is that I don't want to just make the teams bigger as they were before, because that way we're not addressing inequalities. And how do we weave it into the DNA of the organization that everything needs to be done in terms of equalities and inequalities as well? Thank you.
Yeah. So I might say something about that. So at SAM, we are actually one of the pilot sites for the PCREF, the Patient Care Rating Policy Framework, and that is held at board level. And this is a similar type of approach. It should be held, it needs to be held by the leadership of the organisation that is delivering it, because it has to be something that it's not meant to be another project alongside. It's something that weaves throughout everything you do. So it's actually changing the approach and changing the policies, procedures, and processes by which, in the way that you work, essentially. And so it does need to be held at the board level.
Okay, thanks for that. I see the networking's already started. So from Alice Seaborn says in the chat that she can see that there's a colleague from another part of Greater Manchester. Will this be something we could do at STP level? I guess we've kind of answered that, but does any of you want to say anything about, you know, working across boundaries? Of course, when the white paper goes through and it becomes law, as I'm sure it will be, the governance will be much easier because it can be done just through the single organisation, through the ICS. I guess at the moment, if you're working across organisational boundaries, you have to get agreement in each organisation. So that might actually be one of the improvements from the legislation. But does anybody want to come in further about working across organisational boundaries?
I think it's great to bring partners in. What we've learnt from applying quality improvement to this kind of topic has been that the higher and the greater the scale you start thinking at, the further you obviously are from the person. So, you know, lots of these changes are going to be most meaningful done locally with the local communities, and you need to start very small with that to really understand assets that exist in neighborhoods. And so that's one of the things to balance, you know, wanting to bring in partners with the need to really remain true to localism and what matters to our local people.
Okay, Jono or Lade, do you want to come in on that?
I think I just agree with what Amar said there, actually. I think that's absolutely right, spot on.
Yeah, I agree. And I think just in the context of Lade's introduction, talking about lots of those social determinants, fully aware that we tend to get people when they present with an illness or a need of some sort of support. And if, you know, ICSs, I think, are a really good opportunity to link in with those community assets, to just encourage early access and, you know, master the basics through things like faith groups and other groups that we know are traditionally not as well engaged by NHS services.
Adrian, could I just quickly jump in? Hi, everyone.
Yeah, do please, Mark. Yep.
Hi, I'm Mark Farmer. I'm the carer member of the project team on this. And I also happen to chair the mental health design group, it's called, for our CCG and STP. So they lead this across the system. And just to say, from my perspective, even in the current system that we've got, so our area has only just had approval for an ICS, actually. But we are working on provider collaboratives and other things. But just to say, we very much see it as the system being responsible for tackling inequity in mental health. So that's where this project will help land some of those conversations across our CCG and STP setup. So I think those conversations happen anyway, don't they? But it's just making sure that, you know, mental health is a priority in as many areas as possible. And I think you, Adrian, you said that, didn't you, at the start? But I think this is an exciting opportunity. And I just want to say one thing. Perhaps we need to worry less about structures and focus more on impact for patient and carers. That's the driver for all of this. So that's what's always worth bearing in mind.
Mark, thanks so much for that. And obviously, this is all about impact, really. It's about actually making a real difference to patients. There's a question in the chat about start date, which Dominique has answered already. So looking to launch in May 2021, there'll be an initial setup phase for organisations taking part and to get teams in place. Further down, Amar, you've answered some questions. So, okay, I'll go back up to the hands. I can't see any more hands up. Is there anything? No such thing as a bad question. Oh, Lynn, you're to come back in.
Yeah, I just wanted to come back to something that Amar was saying, because I think there is, for me, there's just, although it would be great to have the ICS system as a driver, there is something about balancing between that, what Mark was saying, you know, impacting on patients and carers and communities, but actually biting off something in terms of developing a project or an area of improvement that you can actually test out quite quickly and get those improvements started. Because I think otherwise it starts to become a big beast, if that makes sense, and often, you know, that's when projects don't work well, because actually too complicated and we've put too many things in. So I suppose I'll defer to Amar because he's got way more experience on a national level, but I just think that, you know, for me it is about trying to just kind of, as you said, focus down on a specific area where we know there's a specific need, and then knowing that our services are delivering in that particular area, what we can do differently and better that would then actually support you know, reducing the inequalities. And I'm thinking particularly about Leicester City, to be honest with you, and what we've been through in terms of COVID, and the stark reality of the inequalities that has become known to us. So I guess my question is really, it's probably better to start smaller, if that makes sense. You might have lots of partners, but you've got to do the do, haven't you? And you've got to get it moving and make it happen, I think, in the first instance.
Thanks, Lynn. Yes, absolutely. So does anybody else want to come in? You can be a question. You can. This is a collaborative. It's about learning from each other. You may have a important point to make that could help the collaborative. I've noticed that the CMO is talking more about inequalities, mostly in relation to the pandemic. And in fact, I've got a meeting coming up in the next week. I've organised with him and Michael Marmot to look at inequalities, especially in relation to mental health. And I'm really hoping to make this central to his agenda going forward. So he'd be a very powerful ally. So we have a hand up, I think. Laura, you wanted to come back in.
Yes, just I'm thinking out loud, so forgive me. It's just based on what Lynn was just saying, and following your comment, Adrian. It's something about the balance, isn't it, between the proactive and coordinated work within the ICS, so that we are, as communities, looking at the best way of meeting the needs of our populations and understanding that to the best of our ability. And that's really to support people so that they don't have to engage and answer questions and have more and more interfaces with many organisations, because, you know, many of us use many organisations in our patches. So we need, as partner organisations, to be more proactive in doing that. But this is about advancing mental health equality. And my worry is if we divert the whole project, and I think this is where Lynn was going with this, divert the whole project into an ICS, the mental health provider is only a part of that, and we will lose focus and our ability to manoeuvre perhaps as much change as we might be able to faster within the organisation. So this is going to be a really careful balance, isn't it, of best meeting the needs of our population, and that's holistic needs of the people who use all of our services, versus mental health providers and people who provide learning disability services, to ensure that they are providing the right intervention and at as fast a pace as they are able, without being hindered by working at system ICS level. That, just thinking on my feet, sorry.
Great, really important point. So thanks for making that, Laura. Another question in the chat: is Don Berwick involved at all? Amar, I think you probably answer that. Do we need Don Berwick when we've got you, Amar? Be my question.
Oh my goodness, yes, but so Don and I, and Derek Feely and I have been really doing a lot of work across the ICSs already around equity and vanguards, and we've been applying the quality improvement to achieve the triple aim, really putting equity right at the forefront of the design process at Elft with the IHI's help over the last 3 years. So I've learned quite a lot about this. I'm not sure whether Don is directly involved, but he's certainly been influential in the development of the ICS, with the triple aim being sort of stated as the core statutory purpose of the ICS, potentially.
Okay. That's great. Well, we're all very busy. I don't want to delay things if we've got all the questions in the chat. There is a question about the deadline for joining the programme, and so I think that very neatly I can pass over to Dominique, who's going to talk about the next stages. So over to you, Dominique, and again, thank you so much for all you've done in bringing this together.
Thanks, Adrian. I'm just going to stick up a slide because it's got a couple of dates on. Hoping everyone can see that now. So the next steps, I've just seen the question in the chat asking whether the deadline for submitting expressions of interest is the 26th. So it is the 26th. But this is really more to help our team with planning to gauge sort of the level of interest. So if you miss that deadline, it doesn't mean that you can't take part in the programme. But if you are able to submit the form, it only takes a minute or two. It will really help us with planning. As has been mentioned a couple of times, I think it's a good chance now to start having conversations within your organisations about who might lead this work and how you might want to go about doing things, and keep an eye out for further details on how to apply. I'm hoping to launch the formal registration process on the 5th of April. So by then we're looking to be able to sort of confirm like dates for the launch, the price, and all the sort of details that you need in there to be able to confirm. But then if you've got I think it's 4 weeks that you'll have to submit your formal registration to say that you do want to take part. And I'll circulate the details to that both to everyone on this call and everyone that submitted the expressions of interest as well. But yeah, so do keep an eye out for that. I think that's it in terms of next steps. Are there any questions around any of that?
Any questions? Well, it would appear that all the queries have been answered, so thank you all so much. I mean, in terms of each of you, do you want to just come back and to make one final point? Lade, do you want to make a final point, and then we'll go to each of the presenters and then we'll finish?
I think, you know, from my point of view, this isn't a new thing about mental health inequalities. We've known about this for about 40 or 50 years, and the evidence is compelling. It's the same evidence, but we don't ever quite manage to address it. And this is an opportunity now to start learning how to address it, really. So, you know, whatever you decide to do, please do something.
Great, thanks, Lade. And Jono, did you want to have a concluding comment?
Yeah, I was just going to say, I think one of the benefits, having looked at the, like, you know, very familiar with the resource, and I think one of the highlights that I would say is that you can kind of do two things at once with it. So I think we've spoken today about like the ask on mental health trusts, and I think it's fair to say that mastering the basics is a really important step. So capturing fluent data, all that stuff that sounds like a bit of a bore. But then I think the good thing about the AMHE is that it can allow you to look beyond that and do that at the same time, and that's where that sort of like fitting it in with the ICS agenda comes to play. So I think the beauty of this particular approach is that you can do two things in parallel, and I think that's where we all sort of want to go.
Okay, thanks, Jono, and thanks for giving up your time today to join us. And Amar, do you want to say the final, pretty well the final word?
Just two things to say. That one, you know, over the last 5 years, we've all built up our quality improvement expertise and knowledge across our providers, and now we need to start using it to tackle the really hard stuff like this. And the second thing is that, you know, just trying to do this work at ELF over the last few years has just generated so much creativity. It's been really fun and exciting. So I'm sure we'll all enjoy it.
And proven to improve staff morale as well. I mean, why wouldn't it? If you can actually make a difference, then you feel better about the work that you're doing. So thank you, particularly for all of you, for your interest and for joining us. If you don't decide to join the collaborative, we hope that you will. As Lade said, do something. Do something, and this is, I think, a real opportunity to make a real difference. So thank you to all of you for joining. Best of luck with your plans. Thank you to our presenters, and thank you, Dominique, for all the work you're doing in organising this. So enjoy the rest of your day. I think you've got an extra 7 minutes that the Royal College has given you, so enjoy it. Thank you very much.